Hi friends, in this series of respiratory system examination, today I will talk about dyspnea. First is the disclaimer. Caring Dogs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided here should be used for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Dyspnea, as we know, it is a shortness of breath, and it is a subjective sensation of uncomfortable breathing of varying sensation with varying intensity. It is a common symptom which affects millions of the people, and it may be primary manifestation of respiratory, cardiac, neuromuscular, psychogenic, systemic illnesses, or a combination of these. It can be either acute or chronic with acute and may occur hours to days, and in cases of chronic, it may occur for more than 4 to 8 weeks. Coming to pathophysiology, it is because of multiple interactions of the signals and the receptors in the CNS, peripheral receptors, chemoreceptors, and mechanoreceptors in the upper airway, lungs, and the chest wall. The respiratory center in the brain is consisting of three groups of neurons. These are the dorsal and the ventral group and the pontine group. The dorsal medullary group controls inhalation, ventral medullary group controls exhalation, pontine group it modulates the breathing intensity and frequency. In pontine group we have pneumotaxic center which limits the inhalation and apneustic center which prolongs and encourages the inhalation. Each of these groups communicate the another to work together for pacemaking potential of respiration. The mechanoreceptors they are located in the airway, trachea, lungs, pulmonary vessels, and they exist to provide sensory information to the respiratory centers of the brain regarding the volume of the lung space. There are two primary types of thoracic sensors or mechanoreceptors: slow adapting stretch receptors or slow adapting stretch spindles and rapid adapting irritant receptors. The slow acting spindle sensors convey only the volume information. However, the rapid acting receptors they respond to both volumes of the lung information and chemical irritation triggers such as harmful foreign body agents that may be present. Both types of mechanoreceptors these mechanoreceptors signals by 10th cranial nerve that is vagus to the brain to increase the rate of breathing, volume of breathing, or to stimulate the errant coughing pattern in response to irritants in the airway. The peripheral chemoreceptors they consist of carotid and aortic bodies. These functions are they monitor the partial pressure of the arterial oxygen in the blood. However, hypercapnia and acidosis increases the sensitivity of these sensors, thus playing a partial role in the receptor's function. The carotid bodies are located at the bifurcation of the common carotid artery, and the aortic bodies are located within the aortic arch. Once they are stimulated by hypoxia, this sends signals by the cranial nerve, ninth cranial nerve that is glossopharyngeal nerve, to the nucleus tractus solitarius in the brain, which in turn stimulates the excitatory neurons to increase the ventilation. And it has been seen that carotid body they constitute about 15% of the total driving force of the respiration. The central chemoreceptor they hold the majority of control over the respiratory drive. They function through the sensing pH, that is changes within the CNS. The primary location is within the brain, including the ventral surface of the medulla, retrotrapezoid nucleus. The pH changes within the brain and the surrounding cerebrospinal fluid is derived primarily by the increase or decrease in the carbon dioxide level. The carbon dioxide is a soluble lipid molecule that freely diffuses across the blood-brain barrier. And this characteristics of carbon dioxide proves to be rather useful in that rapid change in pH within the CSF. The chemoreceptors responsible to pH changes are located on the ventral surface of the medulla, and these areas, as they become acidic, the sensory input is generated to stimulate the hyperventilation, and carbon dioxide within the body is reduced through the increased ventilation. And when the pH rises to more alkalotic level, the hypoventilation occurs and the carbon dioxide levels in the body increases secondary to decreased ventilation. The respiratory center is located within the medulla oblongata and pons of the brain stem and are responsible for generating the baseline respiratory rhythm. However, the rate of respiration is modified by allowing for aggregated sensory input from the peripheral sensory system, which monitors the oxygenation, and the central sensory system, which monitors pH and indirectly carbon dioxide level along the several other portions of the cerebellar brain modulate to create a unified neural signals. The signal is then sent to the primary muscles of the respiration, the diaphragm, external intercostals, scalene muscle, along with the other minor muscles of the respiration. So the breathing process, in nutshell, we can say the sensors they detect the changes in the lung volume, oxygen, carbon dioxide. They send signals to the brainstem, respiratory centers. The brainstem processes the information, adjusts the breathing rate and depth, and then signals they are transmitted to diaphragm, external intercostal muscle, scalene muscles, and other minor respiratory muscles. So the mechanism of dyspnea involves peripheral and the central chemoreceptors. Peripheral chemoreceptors are located in the carotid and aortic bodies. They are sensitive to changes in oxygen, PCO2, and hydrogen ions. Central chemoreceptors present in the medulla, they are sensitive to changes in PCO2, changes in pH of the CSF fluid, but they are not sensitive to PO2. Airflow obstruction also plays an important role in the mechanism of dyspnea. Airflow obstruction because of pulmonary diseases like COPD, tracheal obstruction, decreased pulmonary compliance also plays a role in mechanism of dyspnea, as seen in pulmonary edema, fibrosis, allergic alveolitis, restrictive chest expansion because of ankylosing spondylitis, respiratory paralysis, kyphoscoliosis. They also play a role in mechanism of dyspnea. Increased physiological dead space as seen in consolidation, collapse, pleural effusion, pulmonary edema, chemoreceptor, J receptor, muscle sphincter in the intercostal muscle, and the diseases with impaired muscle function like poliomyelitis, Guillain-Barré syndrome, myasthenia gravis. All these play a major role in mechanism of dyspnea. This is a diagrammatic picture which depicts the mechanism of dyspnea. So, in nutshell, we can say hypoxia, acidosis, or hypercarbia, decreased lung compliance, airway resistance. They are all responsible for the mechanism of dyspnea. Hypoxia stimulates carotid body, leads to dyspnea. Acidosis or hypercarbia stimulates the medullary chemoreceptors, leads to dyspnea. Decreased lung compliance causes lungs and muscle mechanoreceptors stimulation and leads to dyspnea. Airway resistance leads to stimulation of the airway receptors, leads to dyspnea. Coming to another form of dyspnea, that is orthopnea. It develops in recumbent position, means patient develops dyspnea when he lies down or in a supine position, and it is relieved by sitting up or elevation of the head with pillows. Patient here struggles to breathe when lying flat. Patients with orthopnea, they find relief by sitting upright or adopting a more elevated position like being propped up with pillow, and this condition is often linked with heart failure. The severity can be graded by number of pillows used at night, for example 3 4 pillows for orthopnea. Pathophysiology of orthopnea is it is caused by pulmonary congestion during recumbency. In the horizontal position, there is redistribution of the blood volume from the lower extremities and the splanchnic beds to the lungs. In normal individual, this has little effect, but in patients in whom the additional volume cannot be pumped out by the left ventricle because of the disease, there is significant reduction in the vital capacity and the pulmonary compliance with resultant shortness of the breath. Additionally, in patients with congestive heart failure, the pulmonary circulation may already be overloaded and there may be reabsorption of edema fluid from the previously dependent parts of the body. The pulmonary congestion decreases when the patient assumes a more erect position, and this is accompanied by improvement in symptoms. So, the pulmonary congestion during incumbency because failing left ventricle cannot pump out more blood. It is seen in congestive cardiac failure, bronchial asthma. When there is, it leads to increased venous return. When there is diaphragmatic elevation, also leads to decreased vital capacity. So the conditions which are associated with the orthopnea are heart failure because of constrictive pericarditis, left ventricular failure, COPD, bilateral diaphragmatic palsy, asthma triggered by gastric reflux and grass ascites, they all contribute to orthopnea. This is the mechanism. Patient lies down or in the horizontal position. There is redistribution of the blood volume from the lower extremity to the heart. There is in the left ventricular failure, patient is not able to pump out extra volume of blood. There is backflow of blood to the lungs. Pulmonary congestion leads to dyspnea. When there is diaphragmatic paralysis or lung collapse, there is elevation of the diaphragm that leads to decreased total or decreased vital capacity, and it further leads to dyspnea. Coming to paroxysmal nocturnal dyspnea, here the patient has attacks of dyspnea which occurs at night and awakens the patient from the sleep. The mechanism involved is it may be caused by mechanisms similar to those of orthopnea. The failing left ventricle is suddenly unable to match the output of a more normally functioning right ventricle, and this results in pulmonary congestion. Additional mechanism may be responsible in patients who experience the PND during the sleep, or there is decreased responsiveness of the respiratory center in the brain during the sleep and pulmonary congestion, and also due to increased sympathetic activity during REM sleep that occurs 2 to 3 hours after the onset of the sleep. Absorption of the edema fluid with the increase in right ventricular output causing overfilling of the lungs, and it takes 10 to 30 minutes for recovery after upright posture. Specific signs of LV dysfunction, and that includes ischemic heart disease, aortic valve disease, hypertension, cardiomyopathy. The all leads to LV dysfunction and may be responsible for PND. So it has a very low sensitivity, less than 30%, but specificity is high, and this is 75%. It can diagnose the heart disease. So the mechanism here is due to gradual redistribution, reabsorption of the lower extremity, interstitial edema into the circulation. There is increased intravascular blood volume, increased venous return to the heart and the lungs, pulmonary congestion occurs, and patient develops the dyspnea. The difference between the paroxysmal nocturnal dyspnea and orthopnea, as we know that PND occurs 2 to 2.5 hours after sleep. Dyspnea is seen in when the patient assumes a recumbent position or the supine position. Patient wakes up from the rapid eye movement sleep in the PND, and but orthopnea, It is not linked with the sleep. It occurs soon after lying down. How do the patient gets relief? In PND, patient sits up with legs hanging down, stands up, or air hunger is there. The patient self ventilates of comfort. In orthopnea, patient gets up, uses more pillows, and sleeps in erect posture. The mechanism involved in the PND are depressed respiratory center leads to sympathetic overactivity during REM sleep, leads to increased catecholamine surge, resulting in tachycardia, leads to interstitial pulmonary congestion, leads to respiratory center lags behind, and which is perceived as an acute dyspnea, and there is sudden transient increase in pulmonary capillary wedge pressure. In orthopnea, there is shifting of the venous blood more than 400 ml into the pulmonary circulation. There occurs VQ mismatch. There occurs compression of the diaphragm, postural diastolic dysfunction. There is slow, sustained rise in intrapulmonary capillary wedge pressure. The patients of PND may have associated symptoms like angina, perspiration, palpitation, but rarely hemoptysis. The patients of orthopnea have all the symptoms of congestive cardiac failure. In PND, there is transient hypoxia. Transient hypoxia is not seen in orthopnea. The differential diagnosis of PND is nightmares, panic attacks, nocturnal hypoglycemia, obstructive sleep apnea. In orthopnea, patients have patient have a differential diagnosis of COPD, gross obesity, acute asthma, and gross ascites. Coming to trapopnea, trapopnea is the aggravation of dyspnea when lying on a side and it is relieved by lying on opposite side. The causes are unilateral lung disease, that is uninvolved normal lung receives more blood supply due to gravity. There occur congestive heart failure. Patients of congestive heart failure lying on the right side increase, increases the venous return and sympathetic activity. Patients with lung tumor, the gravity induced compression of the blood vessels or lungs. So, patient lies on the affected side. There occur gravitational force causes more blood goes into the lower zone of the lung. There is increased perfusion, decreased ventilation in the diseased organ. VQ mismatch occurs and leads to hypoxemia or hypoxia, and there is worsening of the dyspnea. Platypnea is dyspnea on sitting or standing and it is relieved by supine position. The causes are venous to arterial shunting seen in lung bases, intracardiac shunts as seen in ASD, pneumonectomy, intrapulmonary right to left shunt, hepatopulmonary syndrome, pulmonary embolism, COPD, acute respiratory distress syndrome. Here, patients, when in the sitting position, there occur gravitational force causes more blood goes to the lower zone of their lungs. There is increased perfusion, decreased ventilation, which leads to VQ mismatch, and patient has dyspnea. Bedopnea is a new term described when the patient with heart failure uh, assumes a bending position or tries to knot his laces of the shoes. He experiences the dyspnea. It is because of increased ventricular filling pressure during the sitting or bending. Particularly, it is seen in patients who are suffering from cardiac failure with low cardiac index. So, whenever the patient of dyspnea comes to us, we have to approach it like this, depending upon the onset, whether it is a rapid onset, gradual onset, slow onset. Rapid onset, that is which occurs within minutes to hour. The causes are pneumothorax, acute asthma, pulmonary embolism, pulmonary edema, foreign body. Gradual onset dyspnea means which occurs hours to days. It is seen in pneumonia, pleural effusion, anemia, Guillain-Barré syndrome. Slow onset uh, dyspnea means months to years occurs in pulmonary tuberculosis, COPD, carcinoma, fibrosing alveolitis. Depending upon the severity, the dyspnea is classified as per Medical Research Council, Modified Medical Research, and NYHA classification, which I am discussing in further slides. depending upon the aggravating and the relieving factors. The dyspnea, which improves on weekends and holidays, it is seen in occupational condition like asthma, extrinsic alveolitis, aggravates on recumbency and sleep as, for example, PND and orthopnea. I have already discussed. Depending upon the associated symptom, dyspnea, which has pleuritic chest pain, seen in pneumonia, pulmonary infarction, rib fracture, pneumothorax, central non-pleuritic chest pain, seen in myocardial infarction, massive pulmonary embolism, dyspnea associated with cough or wheeze, seen in asthma, pulmonary embolism, pneumothorax. The Medical Research Council grading of the breathlessness, here it is grade 1 is not troubled by breathlessness except on sternus, not troubled by breathlessness except on sternus exertion. Patient feels. Second is the shortness of breath when hurrying on level ground or walking up slight hill. Grade 3 is walking slower than the people of the same age or stops after 15 minutes when walking at own pace or on level. Fourth is patient stops after walking 100 yards or 90 meter or after few minutes in the level ground. And fifth grade is patient is too breathless to leave the house or dress or undresses, means patient has very much dyspnea, he has high dyspnea and is not able to dress himself or undress himself and he can't leave the house. This is the modified medical research council grading of the breathlessness. It is usually used for the respiratory diseases. Grade 0 is when the patient only gets breathlessness with sternus exercise. Grade 1 is when he gets shortness of the breath when hurrying on the level ground or walking up a slight hill. Grade 2 is on the level ground he walks slower than the people of the same age because of breathlessness, or he has to stop for breath when walking at own pace on the level. Grade 3 is he stops for the breath after walking 100 yards or after few minutes on the level ground. Grade 4 is he is too breathless to leave the house or breathless when dressing. The pitfalls or drawbacks of the modified medical research council grading are the this scale quantifies disability attributable to breathlessness and is useful for correcting baseline dyspnea in patients with respiratory diseases only. It describes the baseline dyspnea but does not accurately quantify response to treatment of the COPD. Then we have NYHA, that is New York Heart Association classification of the breathlessness. It is seen in patients with, it is usually done in patients with cardiac diseases. And here we, besides dyspnea, we also take into consideration chest pain, fatigueness, palpitation, and anginal pain. The class 1 is mild NYHA classification. The patient with cardiac disease but without resulting in limitation of the physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, dyspnea, or anginal pain. Class 2 NYHA is patient with cardiac disease resulting in slight limitation of the physical, means patient has a slight limitation of the physical activity but they are comfortable at rest. Ordinary physical activity results in fatigue, palpitation, dyspnea, and anginal pain. Class 3 is moderate NYHA. Patient with cardiac disease, here they have marked limitation of the physical activity, they are comfortable at rest, and less than ordinary activity cause fatigue, palpitation, dyspnea, anginal pain. Class 4 is severe. Patient with cardiac disease, they resulting in inability to carry on physical activity without discomfort, and the symptoms of the heart failure or anginal syndrome may be present even at rest. If any physical activity is undertaken, the patient's discomfort is increased. This is class 4 and it is severe form of NYHA. So how do we differentiate dyspnea as acute versus chronic? The acute causes of dyspnea, cardiovascular causes are cardiogenic shock, cardiogenic acute pulmonary edema. The respiratory causes of acute dyspnea are acute severe bronchial asthma, acute exacerbation of COPD, spontaneous pneumothorax, pneumonia, acute pulmonary embolism, acute respiratory resistance syndrome, inhaled foreign body, especially in children, lobar, collapse, laryngeal edema, Non-respiratory causes or non-cardiac causes are metabolic acidosis, diabetic ketoacidosis, lactic acidosis, uremia, overdose of salicylate, ethylene glycol. The chronic causes of dyspnea are cardiovascular causes. Chronic cardiovascular causes of dyspnea are chronic heart failure, myocardial infarction. The chronic respiratory causes of dyspnea are chronic obstructive pulmonary disease, chronic bronchial asthma, bronchial carcinoma, interstitial lung disease like sarcoidosis, fibrosing alveolitis, extrinsic allergic alveolitis, pneumoconiosis, chronic pulmonary embolism, lymphatic carcinomatosis, large pleural effusion, severe anemia, obesity, and deconditioning. The non-respiratory causes for chronic dyspnea are psychogenic, hyperventilation because of anxiety or panic related. So acute severe breathlessness can be because of pulmonary edema, massive pulmonary embolism, acute severe asthma, acute exacerbation of COPD, severe pneumonia, tension pneumothorax, foreign body, epiglottitis, mm, epiglottitis, metabolic acidosis, and psychogenic. Red flags for serious form of dyspnea are hypotension. When the patient of dyspnea has hypotension, respiratory rate is more than 40, altered mental status, hypoxia, cyanosis, stridor, breathing efforts without air movement, tracheal deviation with unilateral breath sounds, and unstable arrhythmias. This is the algorithm for the evaluation of patients with dyspnea, which I have taken from Harrison's Principles of Internal Medicine. Showing, showing gratitude is one of the simplest yet most powerful thing human can do for each other. It was said by Randy Pausch. With this, I conclude my today's topic. Thank you. Keep learning.